Well, bigger the better. I don't know. Likes doesn't reply to everything. Just change the idea. Small person knife. I don't know. Everything has its own ability. You can't exchange thing for the other. Bigger surgeons, bigger features. That was something of the past. Not discussing the conventional CMP all the time for the surgery. We are trained as a posterior surgeons, giving that much training seasons as learning schools. We have been doing that. But things changed. What ideal approach should be? That is bigger incision for. I mean, that's the conventional one. We all know this. That was the two-incision approach that came and went wrong. That was the mini here as well as posterior to one. But what I learned latest and the best, which has come up and is quite easier to do, is the super power. That means the supercapsular percutaneously assisted prototype replacement. As compared to the traditional approach, which requires that much incision is not a big thing. Nothing is happening here. To approach, I told you, direct anterior, lateral, posterior, but no one has thought of doing this superior. So that was the advantage with this super path, that only a small incision and you are only superiorly cutting the things. So the advantage with this approach, I'll tell you the advantage. Let's just see what the approach is. Position is similar to what it is in normal. This is called as the home position. The incision is around 2-3 inches above the lateral as we do in kneeling. During incision is separate the posterior border of nucleus medius, that is with the observator, you lift it anteriorly. That is the most important thing. You should not mistake the posterior border. And after that, Dr. Jimmy Chow used to separate between the external rotators and the border of nucleus minimus. Nucleus minimus posterior border and the piliformis border should be identified. Piliformis is an tendon which is easily identifiable and just anterior to this nucleus minimus. So, given incision, we used to separate both the muscles and then separate the capsule. But I find it easier to go in a single lift all the things together. Give the incision, separate the nucleus minimus and the piliformis along with the capsule. We used to put in the lever, just abduct the hip so that creates space between the muscle. So that space will allow you to put in the levers and that will allow you to go straight to the lift. So that's after that, after you have separated that, the point here is you just need to identify the neck with the whole neck and then you prepare the femur first. Because the advantage in this is when you take out the head, it is the thing taking out the head, you won't manipulate the limb too much. I mean, you are not rotating it too much internally, you are not screwing the tissues here. Put in the two shank screws, roll out the femoral head, and then roll the shank screws, pull it up. So, for leaving the SW, after you have to clockwise taking off the head, for leaving the SW, you don't need to cut the whole thing out. There is a guide, as you can see, and in this guide, this car is put in, which is guided or directed towards the SW. And it is at the angle of 45 degrees. And it has, after putting in the car, you leave the camera inside. It is percutaneously assisted. I mean, the skin, just tension on the skin, which is actually used to be transferred with some of the weight. Whatever you devices, leave the camera inside. And after that, you put in the, take out the car and put in the driver. It will fit into the SW one. Okay, so put in the SW. Okay, then put in the up liner and then you, after you put in the head and then you reduce the, it is the other way. You are not putting the, after putting the stem, putting the head and then reducing it. You should put the head into the liner and then you reduce the neck into the the other way around. This thing is, I mean, this is a tremendous approach, and it is been called the northern approach. You won't cut any muscle layer, it doesn't bleed, except for the some trochanteric vessels on the other side. You don't cut the, just for cutting the gem so that longitudinally, you can stitch it and reform it. The beauty with this approach is that you don't even if you feel that you can't do it in the middle of the surgery or you are not able to do it, extend the approach to your conventional southern approach. And you can do really what you are doing. I mean, there should not be any issue with the converting it to the normal posterior lateral. That was it. The only disadvantage with this approach, what initial stage I feel is, you are not able to see the lesser trochanter. We have been trained to see the lesser trochanter, lesser trochanter, lesser trochanter. But what Jimmy told me was that why you don't see the lesser trochanter? We have been trained like that. The reason being, the John Charlie used to cut the greater trochanter always and he used to keep it back. So what landmark he always used to take was lesser trochanter. So we have utilized lesser trochanter to keep our nose stand like that. But when you don't have lesser trochanter, you always take greater trochanter evaluation. Why not greater trochanter? It is more lateral landmark than the lesser trochanter. So this approach, I think, should be quite easier as compared to other that one initial. This approach, I don't want to confuse things here, is also called as the micro-posterior approach. There is a group of approaches from micro to mini. Mini approach called all the external rotators. The mini posterior approach is according external rotator sacrificing approach. That was done by the Edinburgh, and this was the micro-posterior approach that we did for class. This is external rotating sparing approach. I mean, you won't cut anything, just make a plane and just put it. It is not a hard and fast rule. You don't want to cut it. There is no prestige issue here. Because in really do a bipolar, you are cutting all the 5 complex external rotators, all the tumor pattern deposit. And main thing is, you can cut the bipolar in your initial stages. As gain experience, you are not cutting. That's the idea. Added to this, advantage of this is you are not cutting the facial lata, you are not going down. As Michael Reese in USL, he has studied and proven that, and it's a worldwide fact that causes pain. The facial lata causes pain once you cut it. I mean, if you leave a gap and it will pain in the posterior side. So that is the approach. I mean, what are the advantages? Preservation of the dendroid, that's known to be everybody knows that ideally continuous is preserved. Minimal stretching of this external rotation. Of course, you are not dislocating there. It is where it is, and you are reconstructing the joint there only. And there is a decrease in blood loss. Obviously, you are not cutting anything except for movement. There is accelerated recovery, obviously, and it is also called as northern approach as compared to the southern approach, which we usually do. Patient positioning and landmarks are all familiar because we are all almost 8 we are all serious surgeons. And only single assistant is required. Obviously, in the home approach and the home position, you are keeping the foot on the nail trolley and you don't need an assistant except for holding the levers. That is the beauty, and it is readily convertible. I told you already. If you don't find it comfortable, if you are not easily comfortable, you can shift it to your normal routine approach. So that is the advantage. And as far as it has a shorter learning curve as compared to other posterior MIS as far as the rotators are confirmed, there is no antagonism to external rotators as such, except for the iliofemoral ligament. So external rotators are believed to have a neuromuscular static response. So when you cut that, there is a partial instability, what the literature says, and Jimmy has proved that. And so I will say that this is best as far as of now, as compared to other posterior MIS. And I've been trained with him, and he developed this approach, I think, from 1,000 cases and published that in 2011. And if you do this with this approach, I think nothing is difficult to achieve with this approach. Bigger is not always better.